Good afternoon, dear chair, dear audience. In the next few minutes, I would like to present the current status of my PhD work about the effect of biological treatments on the cardiovascular risk. I'm Noémi, Galajda, PhD student at the Department of Dermatology, and my vision is to reduce the burden caused by comorbidities in immune-mediated inflammatory diseases in IMIDs. And in order to achieve that, I would like to contribute to the optimization of the therapeutic sequence, taking into consideration their effects on the comorbidities. We had two specific goals. In the first project, we investigated the effect of TNF inhibitors on the risk of atherosclerotic cardiovascular events. As you all know, the cardiovascular diseases are among the leading causes of morbidity and mortality worldwide. And the major pathogenical background for it is atherosclerosis, in which a key inflammatory player is the tumor necrosis factor, TNF. This cytokine plays also a pivotal role in the pathomechanism of the IMIDs, and among these patients, there is an increased risk for developing CV events compared to the general population. Biological treatments inhibiting the TNF are widely used biological therapies, and through the mentioned common inflammatory inhibition of this inflammatory pathways, they may have a beneficial effect on cardiovascular comorbidities. However, unfortunately, they are not among the first-line systemic therapies, most probably because of their high cost, whereas the conventional immunosuppressants are much more affordable, but they do not directly act on these specific pathways. So our aim was to investigate the effect of TNF inhibitors compared to the conventional treatments on the risk of cardiovascular events. Our hypothesis was that TNF inhibitors can decrease the risk of CV events compared to conventional therapies. After the systematic search and selection process, we got 56 eligible articles, from which 29 could be included into our meta-analysis. I would like to show you our major findings with incidence rate ratios among IMID patients comparing TNF inhibitors to conventional systemic non-biological treated groups, CSMB groups. And on the first forest plot, we can see major adverse cardiovascular event risk. The overall effect was 0.77, which means that there was an about 20% lower risk in the TNF inhibitor group compared to the CSMB group, and this beneficial effect was maintained for the subgroup analysis as well. These results were not only clinically highly relevant, but also statistically significant. Regarding the myocardial infarction, we could see statistically significant 30% lower risk in the TNF inhibitor group, and this beneficial effect was further strengthened by the results of cerebrovascular events. We could see a clinically remarkable 30% lower risk, which was also statistically significant in the TNF inhibitor group. Our strengths are that this was the first comprehensive analysis including all IMID patients treated by TNF inhibitor, and our subgroup analysis confirmed firstly the benefit of TNF inhibitors specifically in psoriasis patients. However, these were observational studies with highly heterogeneous comparator groups. As a conclusion, we can say that TNF inhibitor decreased the risk of CV events compared to the conventional treatments, and therefore we would recommend the first-line use of TNF inhibitors instead of conventional therapies in high CV risk patients. And as an implication for research, randomized control trials with direct comparisons of active substances would be needed. I'm happy that I can present you that our paper has been accepted by a top D1 journal at the field of dermatology, by the Journal of the European Academy of Dermatology and Venerology. Moving forward to the next topic, our aim was to investigate the effect of TNF inhibitors on the risk of heart failure. Why is so important this topic? TNF inhibitors are generally very safe and well-tolerated treatments. However, they have some contraindications, including heart failure. And what is the origin of this association between TNF inhibitors and heart failure? The FDA in the early 2000s reported a case series of new onset and worsening of heart failure in connection with these therapies. And since then, the therapeutic guidelines include the relative contraindication in milder and the absolute contraindication of the use of TNF inhibitors in more severe cardiac function cases. However, the literature is greatly controversial about it, encouraging us to systematically review and investigate the effect of TNF inhibitors on the risk of heart failure. In this case, we compare TNF inhibitors first to placebo and also to non-biological therapies, and we measured as an outcome the incidence of heart failure, and we hypothesized that TNF inhibitors do not increase the risk of heart failure. After the selection process, we have 52 eligible articles, from which I would like to show you today a preliminary results of 21 randomized controlled trials comparing TNF inhibitors to placebo. And here the effect measure was risk ratio, and you can see subgroups based on the different type of TNF inhibitors. The overall risk ratio was 1.15. We see neither a clinically relevant nor statistically significant tendency towards an increase or a decrease risk of heart failure. Our strengths based on this preliminary result is that the design of the studies, and regarding the whole project, this is going to be the first meta-analysis on this outcome. And as a limitation, we could see that in our cities there were low number of events which can cause potential imprecision in this analysis. And as for now, we have only results with new onset of heart failure. However, we can preliminarily conclude that there we could not see any association between the TNF inhibitors and the new onset of heart failure, and this would mean that even more IMiD patients could have a benefit from this effective anti-inflammatory therapy who have a higher atherosclerotic CV risk, referring back to our first meta-analysis findings. But we should wait for our further results with real-world data of non-randomized studies and for the final validation of this hypothesis. Randomized controlled trials with including heart failure patients would be needed. This is the progress, second project's progress now, and we would like to finish this in March as well. And I would like to thank you for your attention and finish with highlighting the importance of the perseverance set by Albert László Barabási. Thank you.
How do you think that you can translate your findings into the clinical practice? Do you see anything? Can you envision anything that here we can change something in the Hungarian guidelines or do something differently?
Yes, thank you for your question. I think that it can definitely change, specifically regarding the individual patient care or treatment strategies, because now in every guidelines, in also the psoriatic treatment guidelines and in the dermatologic field and also inflammatory bowel disease guidelines recommend this therapy as a second line therapy if the first line conventional systemic treatments are not good enough in efficacy. But in this case, there are a lot of patients with high cardiovascular risk, and as a translation of our results, it can be used sooner. So, if the guidelines would include this, yes.
Do you think you could start treating psoriasis patients, for example, earlier, even if their PASI scores are pretty low, DLQI scores are pretty low, but their cardiovascular risk is really, really high?
Yes, that can be imaginable, yes.